Good afternoon and welcome to the Crohn's and Colitis Foundation IBD Pro Webinar Series. In this webinar, we will welcome distinguished faculty Dr. Parakkal Deepak from Washington University in St. Louis and Dr. Preetika Sinh from the Medical College of Wisconsin to discuss how to mitigate risks and new therapies. The talk will include new medications, how to mitigate risks, and how to discuss those risks with patients. The recording of this webinar and all of the webinars in this series will be available on the IBD Clinical Hub at crohnscolitisprofessional.org. Without further ado, I will hand this over to Dr. Deepak.
Thank you. I'm here today speaking to you on how to mitigate risk with new therapies in IBD with a particular focus on sphingosine 1-phosphate agonists. I'm Parakkal Deepak from Washington University in St. Louis. Here are my conflicts of interest. So we'll start the talk today talking about the sphingosine 1-phosphate receptor modulator mechanism of action. So as we know, lymphocytes exit from the lymphoid tissue, migrate to sites of inflammation in response to signaling cues, and then enter tissue and perpetuate inflammation. The sphingosine 1-phosphate receptor modulates this through a S1P gradient, and the agonist, which is the medication, acts on this receptor and downregulates the receptor to where there's reduced circulation of activated lymphocytes to the intestinal tissue. We have two medications currently that can act as sphingosine 1-phosphate receptor agonists. We have Ozanimod that is currently FDA approved for management of ulcerative colitis and is under investigational trials for its role in Crohn's disease. Etrasimod is another S1P phosphate receptor agonist that is under trials for both ulcerative colitis and Crohn's disease. Let's see what's the difference between the two molecules. Ozanimod acts on the S1P receptor 1 and 5. Etrasimod, in addition to the 1 and 5, also acts on receptor subtype 4. There are other key differences between these two molecules. One of them is that the half-life of Ozanimod is 21 hours, but it also has an activated metabolite that sticks around for 11 days. So it does have a long half-life because of these reasons. Etrasimod, in comparison, has a half-life of just 33 hours. How this also makes an impact is in terms of faster lymphocyte recovery time, which means that once someone goes off of Ozanimod, the level normalizes within 3 days to 3 months of cessation, as shown in healthy populations and in patients with multiple sclerosis. While Etrasimod, because of the shorter half-life, has quicker normalization within 7 days of cessation of Etrasimod. Additionally, Ozanimod has impact on, through the first dose, heart rate reduction effect, which requires dose titration, which we will discuss about in the next few slides. Etrasimod, in comparison to this, because of the shorter half-life, has a more modest first dose heart rate reduction. And currently, the need for dose titration of Etrasimod is under discussion with the FDA. Potential adverse events related to mechanism of action of the S1P receptor modulator class is summarized here in this slide, where the key ones that obviously stand out are the cardiovascular adverse events, including the slowed heart rate, QT prolongation, AV conduction delay, hypertension and hypotension, along with the reduction in absolute lymphocyte count, with a key infection being varicella zoster. In the next few slides, we'll go through potential adverse events with Ozanimod, starting with cardiac adverse events. Let's first start by looking at select exclusion criteria, which are cardiac related, which really govern the key registrational trials for both MS and UC, MS standing for multiple sclerosis. And this is important because we need to know the patients who are excluded from these trials when understanding the data that we will show in the next few slides. So of note, across all the studies, patients who are being treated with class 1A or class 3 antiarrhythmic drugs were excluded. Patients with clinically relevant cardiovascular conditions, including history or presence of recent, which is defined as within the last 6 months, of myocardial infarction, unstable angina, stroke, transient ischemic attacks, decompensated heart failure, especially that required hospitalization, and other cardiac conduction abnormalities as listed here, and severe untreated sleep apnea were excluded from the trials. Additionally, patients with prolonged QT intervals or at risk for prolonged QT interval, and those with a resting heart rate of less than 55 beats per minute during vital signs were excluded. Additionally, patients with any EKG abnormalities that were clinically significant were also excluded. Now, the other key exclusion criteria for the MS trials are listed in green here, and then to the far right, you have the ones from the UC trial in purple. So this has led to the need for dose titration of Ozanimod during induction, which is also true for real-world usage. What does this mean? So a dose at the lowest dose of 0.23 milligrams of Ozanimod is given for the first 4 days of the induction period, followed by 0.46 for days 5 to 7, and then ultimately the standard maintenance dose at 0.92 milligrams starting from day 8 and beyond. So this is mainly because of the first dose cardiac effect that has been noted in clinical trials. To the left of the screen, you have patients and the data from multiple sclerosis, and to the right in purple, you have the patients and the data from ulcerative colitis. What you will see here is that, especially as shown with the 0.46 and 0.92 doses, you have almost a 1.2 beats per minute reduction in the heart rate in the MS patients and about 0.7 reduction in patients with ulcerative colitis. This reaches sort of a complete bottoming out around hour 5 and then goes back closer to baseline by hour 6 in both patients with MS and UC. So a decrease, to summarize, in mean heart rate from baseline is about 0.7 in patients with ulcerative colitis and 1.2 in patients with MS, with the first dose reaching a reduction at hour 5 and coming back to baseline for hour 6. So then next, look at what's the impact of continuous Ozanimod treatment on heart rate, as we know from the maintenance trial. Here again, the distribution of data is on the left, your patient with MS, on the right, your patient with UC. What you'll see here across both the trials is that there is about maybe a 1 beat per minute change in patients with ulcerative colitis, especially those who got Ozanimod during induction and stayed on Ozanimod during placebo. And this was seen as a mean change from baseline to week 52, about 1 beat per minute, as I said previously, for patients who stayed on Ozanimod during induction and maintenance phase. And this data can help us inform how we describe heart rate reduction in patients during real-world usage. So then next, looking at what is the incidence of bradycardia with Ozanimod in the UC trials. During the induction phases, the incidence for bradycardia was about 2 patients per 100 patient years of follow-up. And as we discussed before, on day 1, the first dose effect is seen, bottoming out around hour 5 and coming back to baseline around hour 6. Again, just to clarify that in real-world usage, we do not need to observe the patient for 6 hours in the clinic, but this is just the data that was seen during clinical trials where patients were closely monitored in the trials unit with the first dose. The greatest reduction in mean supine heart rate from baseline was seen at 0.7 beats per minute by hour 5. And about 2 asymptomatic bradycardia cases were noted on continuous monitoring in the Ozanimod group across all the UC induction periods. One of these cases was in a patient with a known history of cardiac disorder, which did not meet exclusion criteria as previously described, and underwent extended monitoring. In this patient's case, the bradycardia resolved on day 7 without any further intervention or the need for interruption of Ozanimod. Next, looking at the incidence of more serious atrioventricular conduction delay-related adverse events with Ozanimod in the registrational trials. Now, looking first at the MS trials, there were no discontinuations due to atrioventricular conduction delays. Additionally, there were no cases of second-degree Mobitz type 1 or higher atrioventricular block observed on EKG monitoring. In the UC trials, across all the controlled UC induction periods, there was one case of a second-degree type 1 AV block reported in the Ozanimod group based on EKG. Importantly, there were no cases of second-degree type 2 AV block or higher reported in the trials. So then this raises the question of what is potentially the population at risk who may have any kind of adverse event if we use Ozanimod in a real world population. So this question was answered using the IBM market scan, which looked at dates inclusive of the ones mentioned on the slide from 2016 to 2021 across all adult patients who were older than 18 and were up to age 65, who had at least 2 or more diagnostic claims for ulcerative colitis within the past 12 months and had continuous medical enrollment for 12 months or greater before the index date. We looked at the prevalence of contraindications to Ozanimod that may be identified with an EKG using ICD-10 codes as listed here across second-degree AV block, complete AV block, sick sinus syndrome, and sinoatrial block. So then looking at the data, we found that the population at risk in this study was about 0.26% of the total population across any cardiac conduction disorder, where about 0.18% had sick sinus syndrome. Now, looking at age-wise distribution as whether they were on any kind of heart rate lowering medication, now looking at patients who were 50 years or older, the presence of any cardiac conduction disorder that may contraindicate Ozanimod did go up to about 0.44%, but importantly, this is still less than 0.5% of the population that may have a pre-existing contraindication that may preclude use of Ozanimod. Switching gears slightly here, going from cardiac conduction abnormalities to impact of Ozanimod on blood pressure. As before, on the left, you have patients who have data from multiple sclerosis, and on the right, in purple, you have patients represented from ulcerative colitis trials. On the top, you have the systolic blood pressure. On the bottom, you have diastolic blood pressure. What you'll note here from the MS studies was that the blood pressure was consistently higher across MS studies and UC studies for systolic and diastolic blood pressure compared to baseline, but not by a significant amount of unit. So to summarize this data, from the phase 3 MS trials, there was definitely an upward trend in systolic blood pressure and diastolic blood pressure after about 3 months on Ozanimod at the standard maintenance dose of 0.92. And this stabilized by 24 and 15 months respectively in the MS trials. In UC trials, the mean systolic and diastolic blood pressure were numerically higher than pre-treatment blood pressure levels. In those who were randomized even to placebo during maintenance phase, but in those who were randomized to placebo, the elevation in the mean systolic and diastolic blood pressure did return to pre-trial values. Now, looking at the incidence of increased blood pressure with Ozanimod in the registrational trials, you will note here that in ulcerative colitis in the induction phase, about 1.2% of the patients were measured to have hypertension. And then during the maintenance phase on patients who remained on Ozanimod, this was up to 2.2%. Again, not a significant proportion of the population. Hypertensive crisis was noted in one patient on Ozanimod in the ulcerative colitis induction phase and the same one patient in the maintenance phase. All patients who had hypertensive crisis had a history of hypertension, which recovered during medical intervention and continued with the study drug even after the hypertensive crisis event during the trial. And the investigators during the trial assessed the relation of events to the study drug as unlikely. Next, let's look at liver enzyme elevation as a potential adverse event with Ozanimod. The incidence of elevation of alanine aminotransferase or ALT with Ozanimod in the registrational trials was looked at either as a greater than 3-fold elevation or as a greater than 5-fold elevation. About 2.6% of the patients in the induction phase had a greater than 3-fold elevation, and this was about similar at 2.3% of those who stayed on Ozanimod in the maintenance phase. All elevations in hepatic enzymes were generally asymptomatic, transient, and resolved without discontinuation of the study drug. More importantly, no cases of severe drug-induced liver injury or meeting Hy's law, which includes elevation of bilirubin, were observed in the registrational MS and UC Ozanimod clinical trials. So to conclude, in controlled and uncontrolled UC studies for liver enzyme adverse events, the majority of patients with an ALT of greater than 3 times upper limit of normal continued treatment with Ozanimod with values returning to less than 3 times upper limit of normal elevation within about 2 to 4 weeks. In other words, they continued to stay on the medication, were treated, and the levels returned to normal. Next, we look at macular edema. Now, it's important to look at certain exclusion criteria that applied to patients in the trial, which may have resulted in lower rates of macular edema, and it's important to understand that. What I mean by that is that across all studies, patients with type 1 diabetes, uncontrolled type 2 diabetes, diabetic patients with significant comorbid conditions such as retinopathy or nephropathy, or those with a history of uveitis were excluded from the trials. Additionally, the summary exclusions for MS studies are shown in green here next to the all studies exclusions, and then finally to the right in purple you have the exclusions for the UC trials. So post-exclusion, what was the incidence of macular edema with Ozanimod in the registrational trials? A total of 3 patients had macular edema during any point in the UC registrational trials, with 1 during induction, 1 during maintenance, and a total of 3, as I mentioned, in the open label extension trial. Most importantly, all the cases of macular edema resolved after treatment discontinuation. Now, what are the potential symptoms of macular edema that one should look out for if one were on Ozanimod? These symptoms include vision changes that can be blurred, wavy, or distorted central vision, colors that appear washed out or different, and difficulty reading. If vision changes do occur while on Ozanimod, evaluation of the fundus of the eye, including macula, is recommended. And in those with a history of uveitis and those with diabetes mellitus should have regular follow-up of the fundus examined as per usual care. Additionally, continuation of Ozanimod in patients with any of these sort of vision changes that may suggest macular edema is not recommended. Next, we look at the next potential adverse event, which is pulmonary effects. Now, importantly, patients with clinically relevant pulmonary disease, which includes anybody with a forced expiratory volume 1 or forced vital capacity of less than 70% of predicted value at screening, were excluded in the trials. Additionally, patients with any clinically relevant progressive pulmonary events were not noted in the UC trials, and hence routine spirometry follow-up is not indicated. Next, looking at the absolute lymphocyte reduction and infections with this medication. In active MS and controlled UC trials, Ozanimod caused a mean reduction in peripheral blood lymphocyte count by about 45% of baseline values, mainly because of a reversible sequestration of lymphocytes in the lymphoid tissue. This happened because of interference with the S1P gradient, as we showed before, that is important for the lymphocytes to exit the lymph nodes, and receptor modulation by the agonist and downregulation of the receptor causes these lymphocytes to get trapped in the peripheral lymph nodes. So after discontinuation of Ozanimod at the maintenance dose of 0.92 milligrams, the median time for peripheral blood lymphocytes to return to normal range was about 30 days, with approximately 90% of the patients recovering to normal within 3 months at a maximum. Specifically looking at more significant drops in absolute lymphocyte count, during the induction phase, the proportion of patients who were treated with Ozanimod and had a reduction to less than 0.2 was about 2%, while this number was 2.3% during the maintenance phase. This then raises a question that is there a correlation between low absolute lymphocyte count and serious or opportunistic infections in patients with ulcerative colitis? This was answered through a pooled analysis of patients who received the standard maintenance dose of 0.92 milligrams of Ozanimod or placebo in the phase 2 and the phase 3 UC trials and the open label extension with data available till March 31st of 2020, which includes about 1,666 patients with ulcerative colitis. And this relationship was examined. So what you'll see here and also shown in the table to the right is that the incident rate of infections per 100 patient years of exposure was actually lower in patients with placebo at 22.81 compared to 31.43 in patients who were on placebo. The majority of patients with an absolute lymphocyte count of less than 0.2 in the Ozanimod group did not actually experience a serious or opportunistic infection. Also importantly, no patients with an actual ALC of less than 0.2 had at any time have an opportunistic infection, including herpes zoster. Now, they did have other serious infections such as appendicitis and pneumonia, but not herpes zoster. Importantly, no patients that experienced an ALC count of less than 0.2 were noted to have such a measurement at the time of any of the serious infections or opportunistic infections or lead to discontinuation of therapy. So then, what is the data for the incidence of infections with Ozanimod in the registrational trials? In ulcerative colitis, this was mainly driven by multiple sclerosis, where about 13 Ozanimod treated patients had herpes zoster and had documentation of a positive varicella zoster virus IgG antibody status prior to randomization. All herpes zoster cases were single dermatome, resolved with oral antivirals while remaining on Ozanimod, and none of them were associated with an absolute lymphocyte count of less than 0.2, and none of them actually needed Ozanimod to be stopped due to the herpes zoster. So they were all milder cases. Now, one case that does evoke some degree of anxiety is that there was one case of primary multifocal leukoencephalopathy, which was reported in March of 2021 in a 46-year-old patient who had relapsing multiple sclerosis who had received Ozanimod at 0.92 milligrams for approximately 4 years in the open label extension trial. She did have to discontinue Ozanimod because of the diagnosis of PML and had a non-fatal outcome with neurologic sequelae present despite the discontinuation. Now, the important thing to note here is that this is not in a patient with ulcerative colitis, and also in this patient with MS who did develop PML, she also had a prior exposure to interferons that could have also increased risk of PML in this patient. So to summarize, the incidence of infections with Ozanimod in the open label extension studies, there were a total of 288 such cases for incident rate of 25 per 100 patient years of any infection. About 22 patients and about 26 patients had serious infections and herpes zoster infections respectively. So key signal for serious infections in these patients and infection signal was because of herpes zoster, which is shown that as one of the most frequently occurring infectious treatment associated adverse event was herpes zoster, seen in about 3.2% of the patients, with other ones being nasopharyngitis, upper respiratory infection, and sinusitis. Finally, before we get to the screening and monitoring, one really brief look at real-world usage coming from the University of Chicago experience. So in their small real-world usage experience, there were a total of 7 patients who had any kind of serious adverse events. These included only 2 events that actually led to a cessation of Ozanimod. One was a case of hypertensive urgency in a patient with hypertension that continued despite initial continuation, and finally, patient had to discontinue treatment with Ozanimod and have specific treatment of their hypertension. And the second was in a patient with fatigue and headache that required cessation of Ozanimod again, and these symptoms improved on stopping therapy. All the other adverse events of acute gastroenteritis, milder fatigue, nausea, mild liver derangement, and chest pain all resolved while still on treatment and did not require drug discontinuation. So now for the final part of our risk mitigation, let's really look at how to use this therapy. Now it's important to understand there are certain contraindications for patients who ideally should not go on Ozanimod, which includes cardiovascular ones, which includes recent or in the last 6 months, patients having experienced a myocardial infarction, having unstable angina, stroke, transient ischemic attack, decompensated heart failure requiring hospitalization, or significant NYHA class 3 or 4 heart failure. Additional cardiac conduction abnormalities such as a second-degree Mobitz type 2 or a third-degree atrioventricular conduction block, sick sinus syndrome, sinoatrial block, or any of these are okay if the patient actually has a functioning pacemaker, which is important to note because the pacemaker would help override any kind of cardiac conduction abnormalities. Now, patients who have severe untreated sleep apnea are also a contraindication, and these patients were excluded from the registrational trials for Ozanimod in UC and MS. Finally, because of drug interactions, any patients who are taking a monoamine oxidase inhibitor are ideally also excluded from Ozanimod usage. Now, what are the screening requirements prior to the first dose of Ozanimod? All patients should have a recent complete blood count within the last 6 months, and this should be done prior to starting the first dose of Ozanimod, which also helps to rule out any kind of infection if the patient has an elevated white blood cell count, which cannot be explained by other reasons such as being on steroids. Patients should have a EKG at baseline to determine whether they have any kind of pre-existing cardiac conduction abnormalities. Again, certain conduction abnormalities may need to be excluded unless they have a pacemaker, and further consultation with the cardiologist should be sought when necessary. Liver function tests should also be recent within the last 6 months so as to exclude pre-existing elevations in transaminases and bilirubin. Fundus exam, including macular, is only required in patients with a history of diabetes, uveitis, or if they have known history of macular edema. Certainly, a detailed examination of current and prior medications are necessary to avoid drug interactions, especially with monoamine oxidase inhibitors, which is an exclusion. Vaccinations should be reviewed, and if a patient requires a live attenuated vaccine immunization, we should administer them at least 1 month prior to the initiation of Ozanimod, or delay the initiation of Ozanimod by a month if one is necessary. Additionally, it is recommended by the manufacturer that one should test for antibodies to varicella zoster virus if you cannot account for prior either chickenpox infection or vaccination, and patients should be vaccinated against chickenpox if the antibody titers are negative to VZV. Additionally, if the patient has had chickenpox, one should strongly consider the Shingrix vaccination. Monitoring during treatment requires looking at blood pressure if patient has a pre-existing history of hypertension. This can be done with ambulatory home blood pressure monitoring machines, which are freely available. Infections, certainly monitor for these during treatment and for up to 3 months after discontinuation, keeping an eye for herpes zoster, and this can be prevented through the Shingrix vaccination. Also being vigilant for very rare infections such as cryptococcal meningitis and any signs for progressive multifocal leukoencephalopathy, which again has only been shown in one case in a patient with MS who also had prior exposure to interferons. Liver function tests should be checked since transient elevations have been reported in especially ALT, although these have mostly come back to normal within 2 to 4 weeks of elevation, even when you continue treatment with Ozanimod. Ophthalmic assessment should be done at certain intervals in patients who have any kind of vision changes, or if they have pre-existing uveitis or diabetes mellitus and the drug is started despite being the presence of contraindications. Pulmonary assessment is not necessarily routinely and is only necessary if patient has any kind of new onset shortness of breath or other pulmonary symptoms that cannot be explained. So with that, I'll stop. Thank you, and I look forward to your questions.
Thank you, Dr. Deepak. And now we're going to hand it over to Dr. Preetika Sinh, who's going to cover the risks with IL-23 inhibitors, the risks with JAK inhibitors, and how to mitigate those risks. Dr. Sinh?
Welcome, everybody, to the information about how to mitigate risks with the new IBD therapies. I am Preetika Sinh. I am an associate professor in Medical College of Wisconsin in the Division of Gastroenterology and Hepatology. And I'm excited to review some of the drugs that are used in IBD and discuss the risks and how we can mitigate those risks. I have no financial disclosures related to the presentation. As for an overview of the slides, I'm going to go over the risks with the IL-23 inhibitor, Risankizumab, also known as Skyrizi, risk with the JAK inhibitors, with the tofacitinib and the upadacitinib, and how to mitigate the risks that come along with these medications. So let's talk about Risankizumab. It's a humanized IgG1 monoclonal antibody that selectively binds to the IL-23 cytokines and inhibits its interaction with the IL-23 receptor. A prior drug, Ozanimod, also known as Stelara, was an IL-12 and 23 inhibitor, like both receptors were inhibited. And then Risankizumab inhibits only the IL-23 receptors. So it's a little bit more selective in that sense. It's approved for Crohn's disease treatment. In the drug trials that were done, the doses were of the induction doses of 600 milligrams IV, 3 induction doses of 0, 4, and 8 weeks. And then after that, the maintenance doses were the sub-Q injections that was self-administered by the patients. The first one is at the 4 weeks after the 8-week mark, and then subsequently every 8 weeks. It's called an on-body injector. It's a little bit bigger than the Stelara pen or the Humira pen that were available before, just because the drug amount is higher that the Risankizumab is being given in these drug trials. And kind of it works out, I think, in the sense that when these trials were done on Crohn's disease patients, the thought was that if we put a higher dose, that might be more effective. And we were not able to, they were put it in an injectable, like a regular injection. So that's why these on-body injectors were put. If somebody might, I was curious enough to know why a bigger injector rather than a regular pen. So that's the reason, just because the drug needed a little bit more space and was not enough to just put in an injection. But I want to kind of go over the risks. So I want to introduce an idea called MACE, because we're going to be using this terminology quite so often in the presentation. MACE is an accumulation of myocardial infarction and other cardiovascular events that are recorded in the drug trials and in subsequent studies that are done for these for the drug. And the MACE events include non-fatal myocardial infarction, non-fatal stroke, cardiovascular revascularization, and that includes percutaneous cardiovascular stents called PCI or coronary artery bypass graft, and cardiovascular mortality. So overall, the terminology for MACE can be different in different studies. And that's why I wanted to emphasize that when you look at a study, look at what are they defining as MACE events. Some define is that these primary endpoints as non-fatal MI, non-fatal stroke, cardiac revascularization, and mortality. Some put it as extended one, in which they include unstable angina or heart failure episodes. So kind of important to know what each study, the MACE means. And MACE means major adverse cardiovascular events. So now looking at the Risankizumab data, in which we see that from the drug trial studies, that we see the infections being a little bit more on the prominent side in the ADVANCE and the MOTIVATE studies. And then the other thing was that the hepatic events were there. But as you see, the MACE events weren't any significant, or if you see the malignancies excluding the non-melanoma skin cancer or the melanoma skin cancer. Now, if you look at the extended maintenance studies, the Fortify study as well, the main things that kind of we look into is the infections that kind of are more in number. You see a little bit more with the 360 sub-Q dosing, but if you see with the placebo group, that also has similar percentage. So again, the injection site reaction, if you see, is more significant in the not significant, but kind of strikes out in the drug group. And that's why I was trying to emphasize a little bit as to why the on-body injector is there as compared to regular syringe. But still, it's not in my clinical practice. I have not seen that it's been pretty smooth with the patients. Hepatic events is something that that's been noted. And again, going back to the on-body injector. So in the initial studies, actually, the patients found that device was quite easy to use. Like if you see 42 out of 45 patients thought it was pretty easy to use. Overall, that was Risankizumab for us. We saw some of the risk profile with the drug trials and other things. Now we move on to the JAK inhibitors. The JAK inhibitor, the first one I want to discuss is tofacitinib. It is an oral non-selective JAK inhibitor that inhibits JAK 1, 2, and 3. And I'll talk a little bit more about what all this means. It's a small molecule, not a biologic, because the way the drug is taken is an oral molecule, and because it is the other biologics that we've used in the past are bigger molecules, and they're not being able to undergo the absorption to the gut. But the small molecule, the tofacitinib, the JAK inhibitors, they can be translocated to the gut, and that is why they are called small molecules. They are intracellular inhibitors of JAK kinases inhibitor, and it was approved for ulcerative colitis in May 2018 as a 10 milligram and 5 milligram twice a day dosing. And the Xeljanz XR, actually 11 and 22 milligram, is now approved for UC as well. So talking about what this all selective JAK inhibitor means, JAK is a molecule that is at the at cell membrane that is activated by some cytokines and growth factors. And the JAK has kind of a JAK1, JAK2, JAK3, and TYK2 that are there in the at the receptor level. So tofacitinib is a JAK1 and 3 inhibitor. And JAK1 is inhibited in specific by upadacitinib. Kind of like to familiarize those words because the selectiveness of the upadacitinib, does it affect overall the risks? And the question, because here we're discussing, is the mitigation of the risk. What happened was when tofacitinib came in drug studies and trials, after that, FDA wanted to do a phase 4 study, is this post-marketing study, in which they wanted to kind of see the specific signals of venous thromboembolism or malignancy in patients. So this was an oral surveillance study that was done from March 2014 to July 2020, in which patients with rheumatoid arthritis, not IBD patients, rheumatoid arthritis, 50 years and older, who had more than one cardiovascular risk factor, like smoking, hypertension, or family history of coronary artery disease, and who had rheumatoid arthritis with external manifestations and a history of coronary artery disease. And then they were randomized to tofacitinib 5 milligram twice a day, tofacitinib 10 milligram twice a day, and then and an anti-TNF group in which they were on etanercept or adalimumab. Most of the etanercept patients were non-US patient population. And then all these patients were also on methotrexate. So there were about 4,000 patients, and then patients on 10 milligrams twice a day discontinued treatment in February 2019, and they were switched to 5 milligrams BID. And the endpoints that we were looking at were the adjudicated MACE and adjudicated malignancies, excluding the non-melanoma skin cancers. What was resulted was that the combined tofacitinib doses versus the anti-TNF had a signal that there was increased MACE events, even though if you see the hazard ratio was 1.33, it does cross the, it's 0.19 to 1.94, but the way the study was structured, they considered that it was, this was considered a significant result. And then, but if you see that tofacitinib 10 milligram twice a day versus the anti-TNF group, there was 1.43. So that was considered a significant difference. But if you see the actual numbers, the number of patients with the first event of MACE, it was 98 in the 2,000 or 3,000 number of patients. That was 3.4. And the incidence rate per 100 patients here was 0.98, so even less than 1. And interestingly, when they did a subgroup analysis, the higher incidence of MACE was seen in patients who were more than 65, smokers, and in the North America part of the study. So kind of giving a signal that it was not in the combined group did give us a signal, but if you tease it out, it was the patients who had some kind of other risk factors that had a higher risk. And interestingly, post-hoc analysis was done that came out earlier this year, in which they saw that the prior history of atherosclerotic cardiovascular disease was associated with prior MACE events, telling us that if somebody has a prior history of coronary artery disease, and what did they define as prior ASCVD? That means a prior history of coronary artery disease, like an MI, unstable angina, or revascularization. or cardiovascular stroke, cerebrovascular event like stroke, or a peripheral artery disease. So saying that those patients already had a risk factor for ASCVD, and then they were seen to have increased risk of MACE events. But based upon the results of the study that came initially, not the postdoc analysis, the FDA said that let's be safe, let's use the lowest effective dose of the drug, and recommended only using this in patients who had failed or had a contraindication to do anti-TNF drugs. And the lowest effective dose means 5 milligram BID or whatever we can use. But if you see this in the drug trials, the safety outcome in IBD studies, you see the MACE and the DVT and the pulmonary embolism is very low. The incidence per 100 patients here is 0.3, 0.04 of DVT and 0.16 of PE. You see the malignancy and the non-melanoma skin cancer risk is less than 1 as well per 100 patients years. The main signal that we are seeing here is herpes zoster. So again, going back to the risk of infection with the herpes zoster. It's a busy slide, but what I want to kind of emphasize is the other aspect. The second thing, other than infection, is the lipid dysfunction. So these patients did have an increase in the lipid levels during the study of the total cholesterol and the triglyceride levels. So that's why these have to be monitored. Does this imply that it increased the risk of MACE or cardiovascular event? That is a different question, because lipid abnormality in IBD patients is still to be understood. And I want to review more of the tofacitinib real world data. These are all drug trial data that came out. They did not show a great signal with MACE events or venous thromboembolism in IBD's population, more of like a signal about zoster. But I will show you more data on the real world data that came out altogether in the end for the JAK inhibitors. Now talking about upadacitinib, which is a JAK selective inhibitor. And it was approved. It's approved both for ulcerative colitis and very recently for Crohn's disease. The induction dose is 45 milligrams orally once a day for 8 weeks, followed by a maintenance dose of 15 or 30 milligrams oral daily. The main side effects that were seen were the common adverse effects for upper respiratory infections, some increase in neutropenia, elevated liver enzymes, herpes zoster, hypercholesterolemia, herpes simplex, some lymphopenia and hyperlipidemia. And those were present in more than 2% of patients on the 15 or 30 milligram dose. If we go into the maintenance phase of the studies and the safety profile, again, we look at the signal that in the UPA group, there was signal about herpes zoster. Malignancies, not that much. The non-melanoma skin cancer was there in the 30 milligram dose, and the other malignancies, exclude non-melanoma skin cancer, was 1 in placebo, 1 in the 15 milligram, and then 2 in the UPA group, 30 milligram group. Educated MACE, 1 in placebo, 1 in the 30 milligram group, and then the VTE was 2 and 2 in the 15 and the 30. And then if you talk about the other things that I would suggest more of a needed more closer monitoring would be the neutropenia and the lymphopenia and the CPK levels and the hepatic disorders that were seen in the study groups. I'm not sure what to make clinically of the CPK levels, but it's something to keep in mind. We do not check for it per se. Now talking about the Crohn's disease studies. The Crohn's disease, also the upper respiratory infection was there was a signal. But if you see the long-term data for the drugs, again, the zoster had a signal, and again, neutropenia and the hepatic disorders was something to consider. The thromboembolic events are not something of very much insignificance. Malignancies, there were 2 in the UPA 30 and then 1 in the 15. There was 1 metastatic ovarian cancer in the patient with the 15 milligram group, and a colon cancer, invasive lobular breast cancer in the patient with the 30 milligram group. I want to tell you that anemia that has been noted in the placebo as well as the UPA group, these anemia numbers were not by actual numbers of hemoglobin level, but more as they were reported by the provider or the physician. Now, coming to the real world data in upadacitinib, especially about VTE and ASCVD, which is atherosclerotic cardiovascular disease. So there was a study done in which they looked at all across all indications of upadacitinib in about 1,500 patients with rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and atopic dermatitis. And they did not find a significant risk of MACE or VTE in these patient groups. So talking about the real world data for TOFA now, there was a pooled analysis of 10,000 patients in the real world studies of 82 studies across various indications that used tofacitinib in RA, psoriasis, IBD, and ankylosing spondylitis. And the MACE events were actually 0.48 per 100 patient years, with an odds ratio of 1.07 crossing the 1, which means that it was not significant. Now we come to the question that, is this all, are we talking about the risk of thrombosis and heart events in the patients on JAK inhibitors, which is kind of gets a concern, becomes a concern? Could it be because of the disease, and or is really because of the drug itself? Because inflammatory bowel disease and cardiovascular disease both are pro-inflammatory conditions with an underlying immune disorder, lipid disorder, and endothelial dysfunction in patients who are genetically predisposed. So there's a common pathway which happens in both disease processes. And in IBD, if you see, there is an increased risk of increased arterial thrombosis events and venous thrombosis event at a baseline. Patients are at increased risk of ischemic heart disease and stroke and peripheral artery disease, mesenteric ischemia, and even venous thromboembolism events like pulmonary embolism and deep vein thrombosis. And it's been shown that these patients, IBD patients per se, are an increased risk in those who are in hospitalized patients and have had prior history of DVT or PE or have had a malignancy factors. So, and it's been shown that if we can decrease the risk by doing thromboprophylaxis, and we can increase the risk by a hazard ratio of 0.46, which is important to know that, yes, we know that the baseline risk is increased in IBD patients, but we can improve the outcomes by thromboprophylaxis. So kind of going into the fact that what we can do to mitigate the risk. Now coming to the baseline risk of heart disease in IBD patients. IBD patients do have a baseline increased risk of 2 to 4 times increased risk of ASCVD. And those are traditional risk factors of ASCVD are there, like high blood pressure, advanced age, male gender, but patients in IBD do not always have the heart disease correlated to their to these risk factors. It's been shown that heart disease in IBD isn't associated with increased disease activity, and even it's been shown that it's kind of deviates from the traditional risk factors that have been shown to be younger patients and female gender have been associated with higher cardiovascular events. So coming back to the fact that is it the disease or the drug? So the disease, as we say, does interplay in increasing the risk. And interestingly, if you see here, I want to show you a little bit of how does JAK inhibitors, the mechanism of action work. It's a busy slide, but kind of trying to focus on the JAK1, JAK2, TYK2. When all these things are activated on a baseline, there's no drug involved here first. So all these when the basic JAK inhibitors, they increase cytokines in the body that actually increase heart failure, increase myocardial ischemia, and cause reperfusion injury, and cause cardiomyocyte apoptosis. So if you inhibit the JAK, actually it should improve your incidence of MACE and improve your risk of heart failure. And that is why the JAK inhibitors are being looked in the cardiovascular world quite a bit as well. But there's one caveat here, is that they do change the lipid metabolism a little bit. They decrease the LDL catabolism and other things. So it has not been studied very well, but that might be some of explanation that why, even though the JAK inhibition should decrease the MACE events and the heart failure events mechanistically, but there's some signal in the rheumatoid arthritis world, not so much in the IBD world. And this needs to be looked into more, that how the mechanism of this drug is working in the IBD. So overall, we see that in the RA patients, we see that increased risk of mortality, MACE events, venous thromboembolism, and lipid abnormality. But again, that is in rheumatoid arthritis patients only, patients who are 50 years and older with more than one cardiovascular risk factor. And more importantly, the postdoc analysis showed that those who had prior ASCVD were the ones that had a higher incidence of these, the venous thromboembolism and the MACE events. So again, we need to know more about the significance of the lipid dysfunction. There is no increased risk of MACE or venous thromboembolism in IBD clinical trials or real-world studies with JAK inhibitors. The role of JAK selectiveness is unclear. And then the role of underlying IBD and interplay of disease activity is also unclear. So all these factors should be kept in mind when we talk about venous thromboembolism and MACE events in JAK inhibitors. I do want to kind of move gears towards shingles, which seems to be a real factor and a signal to keep in mind when we're talking about risks to the patients. So this was a study of all the different combined pooled analysis of JAK inhibitors through various indications. And it was found that the overall, the JAK inhibitors did have an increased risk with 1.57 odds ratio for risk of shingles. Overall, what do you want to do? We do know that there is some increased risk of infections, not so much of an increased risk of malignancies that we are seeing in signals, or we are not seeing a clear signal of venous thromboembolism or even MACE events in the IBD world, in the real world, and in the drug trials with the JAK inhibitors. But overall, let's talk about combining Risankizumab and JAK inhibitors, that how to mitigate the risk. The risk due to the drug, so we need to discuss that, and the risk due to disease. So when we have risk to the drug, what we do is that we try to vaccinate the patients against shingles. So I try to get in at least the first dose of shingles, because there are Shingrix is 2 doses. At least get the first dose in before the initiation of the drug if we can. And then maybe if we can't wait for the second dose, that is fine. It's in 1 month after that. Blood work monitoring should be done as per the protocol, in which we would like to know the liver function and the lipid panel at baseline and at the subsequent interval. In patients who have increased risk of venous thromboembolism, because we know that the baseline patients have increased risk of venous thromboembolism in IBD because the disease itself, we should be proactive about prophylaxis while they're inpatient, and especially post-surgery, because you've seen we decrease the we do thromboprophylaxis, we decrease the risk regardless of the drug. And we see that it is not a clear signal for MACE events or venous thromboembolism, but we should risk stratify patients for their baseline heart disease risk, because we see that those who had baseline heart disease risk were the ones who had increased risk of these heart events. And skin cancer screening should be done in all these patients with at least a baseline risk assessment, and then subsequently 1 year or so as recommended by the dermatologist. Interestingly, for cardiovascular risk in Europe, it's a busy slide. I don't want to go all over it, but just to give a sense that in Europe, actually inflammatory bowel disease, inflammatory arthropathies like rheumatoid arthritis have a set guideline and recommendation how to risk assess patients for cardiovascular disease. And even when they do risk assessment by the clinical risk profiles, they put a factor of 1.5 to rheumatoid arthritis, because they say that the inflammation adds to the risk. We don't have any such recommendation in IBD in US. So this is our suggested recommendations for ASCVD in IBD patients. A baseline risk assessment for ASCVD should be done by a clinical risk score, like an 10-year ACC or AHA risk calculator. These risk calculators only incorporate traditional risk factors. And right now we don't have a factor of 1.5 or something that's been incorporated. But at least a baseline risk assessment would be a good idea. Lifestyle modification should be recommended in IBD patients to improve cardiovascular health, like Mediterranean diet, regular exercise, smoking cessation. And if the disease activity is something that may drive these risks, we should be aggressive about early disease control by early escalation of therapy, especially in young and female patients. Avoid IBD flare. Avoid steroids for long term, which is a known risk factor for heart disease and heart failure. There is some signal that anti-TNFs may be of benefit, but we need to be cautious in severe heart failure of class 3 and class 4. And we should consider ASCVD risk and smoking history when starting a JAK inhibitor. Ozanimod does not increase the risk of heart disease events, but conduction defects should be considered at initiation of therapy. In conclusion, venous thromboembolism and MACE risk is increased in IBD patients. Hospitalized and post-surgical patients should be on venous thromboembolism prophylaxis, regardless of the drug. The incidence of venous thromboembolism and MACE in JAK inhibitors is not statistically significant in clinical trials and real-world studies across multiple indications, including IBD. And even that, the absolute incidence of MACE is low in these JAK inhibitor studies. Most patients who had MACE had known cardiovascular risk or prior ASCVD. JAK inhibitors should be used with caution in older patients with multiple cardiovascular risk factors till we have more data in IBD patients. And there's increased risk of zoster infection in JAK inhibitors with JAK inhibitors in IBD, and shingles vaccine is recommended. Skin cancer screening should be recommended in IBD patients, and Risankizumab for Crohn's disease has a good safety profile. Overall, blood work monitoring for liver and lipid function should be performed. And use of a drug should be based on the risk profile, but also on the benefits of the drug, the ease of administration, the effectiveness, and the response. Overall, more information is needed on risk factors, ways to assess cardiovascular disease, and which drug is appropriate with respect to heart disease in IBD patients. Thank you very much for your attention and for your time, and hope we can have a good discussion and have a more overview of the drugs and the risks to be mitigated. Thank you.
Okay, I think that was sort of the end of the pre-recorded videos, both from myself and Dr. Sinh. And I do want to say, Dr. Sinh, that that was a really educational video, specifically on the risk of therapies with Janus kinase inhibitors and how to think of this in terms of side effects, and of course its robust effectiveness, as we've all sort of learned both from trials as well as clinical practice, and really how to sort of risk mitigate. So I think maybe to start us off, I can read sort of one of the. I think we have two questions here in the chat Q&A box, and again, we are open, and if anyone's coming up with additional questions based on either of the presentations, we are more than happy to take these live and answer these live. But I mean, I'll first start by reading out the one that's already there. So I think Beth Adams asked the question: do people who are young enough to have had the varicella vaccine series need to be concerned about shingles? I thought that patients who did not have a natural infection were extremely unlikely to get shingles. Does it make sense for them to get the shingles vaccine? So, I mean, in theory, if you've never have had the varicella infection, which results in, let's say, what's commonly called as chickenpox, then without the virus, in theory, remaining dormant in the body, you cannot theoretically get shingles. So certainly, varicella vaccination series would be in theory protective, but I think that is something probably it's worth confirming through potentially levels, and certainly for S1P inhibitors, again, I think with that specifically, there's definitely been discussion around the idea of confirming whether vaccination has been done or natural exposure to varicella resulting in chickenpox earlier in life. But I'll also turn it over to Dr. Sinh for her thoughts on this.
Thank you, Dr. Parakkal. Yes, I think for the vaccinations with regard to shingles, it's more of a concern with the JAK inhibitors, as we discussed. There seems to be a prominent signal for the shingles infection. So I guess it would be best to have the shingles vaccine, even if not had prior, if not had prior infection and the consideration that can be reactivated, just because to avoid any shingles that can happen otherwise as well, especially if we can't confirm that the shingles had happened or not happened in the past. We try to get the first injection at least before the start of the drug.
Yeah, I mean, that's sort of vaccination related point, at least for the, which holds true for either of these, is that you want to avoid live virus vaccines and do those at least a month before going on these. But I mean, again, the updated shingles vaccine, that's not a concern. So you can definitely go ahead and get the shingles vaccine done, as soon as possible. Uh, Maybe Dr. Sin, I'll have you maybe address the next question since it has a question with JAK inhibitors.
Yes. So the question is, how often do you have to gather liver function test levels and or recurrent EKGs with the JAKs? So the first thing about the liver function test is, since we did see a signal of liver enzyme abnormalities, the idea would be to get a baseline liver enzyme analysis, and then I usually do it at 3 months, and then after that, like for any other biologic, we do it at 6-month intervals as a routine monitoring. As far as the EKGs, baseline EKGs are not required or needed for JAK inhibitors. Yes, for Ozanimod, to pick up any of the heart blocks that are of concern. But for JAK inhibitors, we do not need a baseline EKG or moving forward. As I was discussing, it's not a clinical practice right now, but it would be good to maybe gather information on baseline heart disease risk factors, though, which are completely different from EKG. Those can be done by the ACC, AHA, clinical risk calculators that are available online and based on traditional risk factors, and whether patient has been on a hypertensive drug or a statin, or what the age is and what their risk factors are.
Can I maybe do a follow-up question on this, Dr. Sin? What is your sense of, in terms of, there have been obviously many different publications, I mean, or at least quite a few publications, maybe not the word many, on risk of, again, various definitions of atherosclerotic cardiovascular disease, variously defined across studies, but showing a consistent signal for increased risk in many different populations. I guess my question I was going to get to was that many of these have shown this clearly an impact of, again, seen in different ways, disease activity, severity with this risk of atherosclerotic cardiovascular disease. So I guess the question I was going to get to is that your sense of how well do the current calculators such as ASCVD plus, or the European kind of score models, how well do they perform in IBD patients, comparable to their performance in the sort of the non-IBD cohort?
And a great question, Deepak, because but even if we say that we should risk assess our patients, IBD patients, for ASCVD or cardiovascular disease, do we have the right tools? Do we have the right modalities to establish a baseline risk for heart disease in our patients? And honestly, we don't. Um, in Europe, the rheumatoid arthritis guidelines suggest that those patients should have a factor of 1.5 added to their risk factor assessment based on the traditional risk factors, because the clinical inflammatory disorder is contributing to the heart disease, and we don't factor that in these risk assessment clinical scores. So definitely there is a need for a better tool for assessment as well. And the other thing would be that we should um, try to develop more tools and compare and have more studies to show that how well are these ASCVD risk scores in IBD patients. We did a very small study of like a pilot study in which we looked at ASCVD score and the coronary artery calcium scores. That also is a risk factor assessment score for 10-year or lifetime risk of heart disease. And we saw that a CAC score of 100 or less, or versus 100 or more, So 100 and less is less risk factor for heart disease, and 100 and more is higher risk. Even the CAC score of 100 and more did not correlate very well with the ASCVD clinical risk score in IBD patients as compared to the non-IBD controls. So again, going back to your question, very valid that we do not have great tools. We do need to kind of develop better tools to incorporate the inflammatory component of IBD.
Great. Thank you.
Yeah.
Yeah. Yeah, I mean, I think you really presented beautifully sort of the results from the oral study. So I was kind of curious when it comes to your own patients, how do you sort of counsel them? The data is in RA and, versus IBD, as you showed, it's not quite there. I mean, that data, even with tofacitinib, and now you have a more selective JAK1 inhibitor in upadacitinib. So sort of, maybe I know we are sort of down to a minute and 16 seconds, maybe like a quick one liner on how do you really sort of present that?
Honestly, I present it as the data is, and then be honest with the patients and tell them that the data is there in rheumatoid arthritis patients for a selective group of patients who already had cardiovascular risk factors, and the subgroup analysis showed that those who had prior heart disease had the MACE events and the VT events. And then we don't have data in IBD in the real world or the clinical studies to show the same signals. But this is what the data is. We need more studies, and that's where we are. So I do kind of modify a little bit for those patients who have had coronary artery disease, not and again as compared to those who haven't.
Great. Well, thank you for the answer.
Oh, thank you. Great discussion, Deepak.
Thanks. I think unless there are other new questions, I'm trying to check the chat box here. Sorry. I mean, maybe there is a question. Thank you for your presentations. Medical trainee, Crohn's patient. I have a question not directly related to your presentations. Curious if there are widely accepted treatment algorithms for Crohn's disease, mild disease versus severe disease. So I think that's probably like the million-dollar question there. I think, I mean, my take on this is that I don't think we truly understand as of yet. There have been some new recent studies, but we don't truly understand what really is mild Crohn's disease. So I think most people really study moderate to severe and has been studied quite a lot and risk factors, but what really is mild Crohn's disease, and are we potentially over treating a certain subset of patients? I think the answer is we don't know, and I think a couple of studies have come out recently, but I think more work needs to be done really to understand what is mild Crohn's disease. Having said that, I think at least I'm of this opinion that, I mean, budesonide and safety, and this is even from patients I've seen recently, that it's always said budesonide safer than prednisone, but I would still be hesitant to leave patients on budesonide long term, because most of the studies showing safety is really shorter term budesonide studies. I don't think anyone's really done very long term studies if you leave people on budesonide. So I would be really hesitant unless we're talking about like a short course therapy. Again, it's sort of outside this particular webinar, I suppose. But again, I think we are trying to get better at sequencing treatments, understanding sequencing. Probably every patient does not need to start with an anti-TNF, but probably there are patients who do need to start with an anti-TNF. So I think our understanding is improving. I mean, I guess Preetika, I mean, any thoughts on your end?
Well, I just said it's $1 million question and the webinar, I guess. But I think in the interest of time, I think we are over time. But I agree with you. There is much more to be learned about the phenotype of Crohn's, since we put everybody in a one box right now and tailor the therapy accordingly.
Maybe one last question we missed. Are you doing pregnancy tests in childbearing ages for JAK or other classes before beginning treatment? I can give a quick answer. I mean, I'm not necessarily doing a pregnant. I mean, obviously patients undergo a pregnancy test for procedures. I wouldn't say that I'm doing a pregnancy test on every woman of childbearing age when they are in clinic and I'm starting to start an S1P agonist. What I talked upon, I'm not doing that. And yes, we do need more safety or more data on safety of S1P agonists during pregnancy, and hopefully some of this is coming through, and maybe I'll have it over to you to comment on the JAK.
As for the JAK inhibitors, currently the data is that we do not encourage patients who are planning pregnancy or to be on JAK inhibitors. So it's definitely not the drug for pregnancy. Do we test for the pregnancy test? No, but it's a matter of, by the time we are doing this for the patients, we already know where they are in their family planning. So JAK is a no for pregnancy.
Yes, great, awesome. I think that that should be it for the questions. And again, thank you for everyone who attended this webinar. I learned a lot from it, and hopefully you did too. And thank you.
Thank you so much. It was great. Thanks, everyone.